Hello, my name is Thumbi. I'm from the Africa Health Research Institute and the HIV Pathogenesis Program at the University of KwaZulu-Natal in Durban, South Africa. I'd like to thank the organizers of this meeting for the opportunity to present during this session on HIV Cure. First, I would like to address the question of why we, particularly those of us in sub-Saharan Africa, should worry about HIV cure and should be involved in HIV cure research. As you can see from this data from UNAIDS, the funding, global funding that we have to sustain current HIV programs, both prevention and treatment, has stagnated over the past decade. And this is even before the onset of the current COVID-19 pandemic. In fact, we have missed the 2020 target set by UNAIDS for sustaining the current HIV programs. This situation is only likely to worsen in the future, and therefore we need to be thinking about alternative approaches to control HIV within our communities. If one looks at the epidemic itself, you can see that the number of new HIV cases, according to this data from UNAIDS, has been steadily declining. And this is as a result of antiretroviral therapy and novel HIV prevention strategies. However, you can see that we are missing the 2020 targets for new HIV infections. Therefore, our HIV prevention programs are not doing as well as they should be. On the other hand, if one looks at HIV infected people or people living with HIV, you can see that the incidence and the prevalence of diseases such as cardiovascular diseases, metabolic disorders, neurocognitive abnormalities, malignancies, and even life expectancy is lower in individuals living with HIV compared to their HIV negative population controls. Overall, therefore, HIV incidence remains high, and we have no vaccine to control this pandemic. And we have a significant HIV-associated multimorbidity. If one focuses on low and middle income countries, particularly among vulnerable populations such as young women, you can see that we still have extremely high incidence of HIV. For example, in this cohort of young women in Durban, South Africa, known as a fresh cohort, HIV incidence approaches 8 per 100 person years, which is unacceptably high. If one then shifts their focus to the population, again, this is data from KwaZulu-Natal, you can see that the prevalence of HIV is extremely high, particularly in certain age groups. In this particular data set, you can see that HIV prevalence among men approaches 40% in those in the age groups of 25 to 44, whereas it is over 60% in women. Therefore, even if we are able to prevent new HIV infections, we have a huge portion of the population that will have to take antiretroviral therapy for the rest of their lives unless an alternative is found. Why do we have such high incidence of HIV? We have many tools now to prevent HIV infection, and this includes antiretroviral therapy, male circumcision, behavior change, including the use of condoms, among others. All these strategies are effective when they are used, but they're suboptimal because they require a lot of behavior change and political will in order for them to be implemented. And currently, we are falling short in the use of these tools that are effective for preventing new HIV infections. Therefore, we need to be thinking about the next generation of tools, and this includes pre-exposure prophylaxis, passive immunization, vaccines, and even modulation of the vaginal microbiome to control new HIV infections. Pre-exposure prophylaxis is of course available currently, but the uptake of this as a prevention tool has been suboptimal, and we need to do much more to encourage communities, particularly vulnerable communities, to take up this as a novel HIV prevention strategy. On the other hand, antiretroviral therapy has been the most successful HIV control strategy. Antiretroviral therapy suppresses HIV replication such that the virus goes to undetectable levels, but unfortunately, it does not cure HIV infection. And as soon as antiretroviral therapy is interrupted, the virus inevitably rebounds. And this is because HIV hides both in peripheral blood, but also in tissues such as lymph nodes within the body. And therefore, in addition to antiretroviral therapy, we need to be thinking of strategies to completely cure HIV infection such that individuals can live without having to take daily doses of antiretroviral therapy. This fact is well illustrated by this data from a study that we are doing in South Africa, where, for example, this individual was treated with antiretroviral therapy soon after they became HIV infected. In fact, within a week or two of becoming HIV infected, this individual had undetectable viral load for almost 2 years. But despite that they were on antiretroviral therapy for almost 2 years, after they started treatment during acute HIV infection, we can still detect HIV within tissues, in this case within the lymph nodes, both in the form of HIV proteins, but also in the form of HIV RNA, suggesting that there is ongoing virus replication in this individual. Therefore, we need to find ways to completely eliminate HIV from the body such that individuals can safely come off antiretroviral therapy. I would like now to address the question of HIV cure research. And the first point I want to make is that there is a huge discordance between where HIV research is being prioritized and funded and where the need is greatest. The vast majority of research and nearly all clinical studies are being done in resource-rich countries, such as the United States. But we all know that HIV is primarily a problem, public health problem in sub-Saharan Africa. And we recently published a review in Nature where we discuss this question and argue that HIV cure research needs to be refocused to focus more on sub-Saharan Africa, where the epidemic is mostly among men as opposed to the West, where it is mostly among, where the epidemic in Africa is mostly among women, whereas in the West it is mostly among men. And we also need to be thinking about the cost and the ease of use of products, as well as other biological factors such as subtypes, host factors, co-infections, which are likely to impact the effectiveness of HIV cure strategies. I would like now to address the question of what do we hope to achieve through HIV cure strategies. When scientists are discussing HIV cure, there are generally two broad approaches that we are thinking about. One is HIV eradication. In this strategy, the virus would be completely undetectable, and this would result in a classic cure. However, this is thought to be, if not impossible, at least at the moment, it's going to be a very difficult task to accomplish. On the other hand, we have HIV remission. And in HIV remission, the virus is present, but at low and detectable levels, whereas the individual is off antiretroviral therapy. So the individual is able to live without antiretroviral therapy, but the virus is present at such low levels that it does not cause any harm, and the virus cannot be transmitted. However, the individual may still remain HIV positive by standard HIV tests. This is a strategy that most scientists are pursuing at the moment, and so for the rest of my talk, I'm going to focus on HIV remission as a cure strategy. So most HIV cure strategies that scientists are currently discussing and researching on involve a combination of reducing the amount of the virus that is circulating in the body, and this is called virus reduction, combined with immune enhancement. So the strategy is to reduce the virus and then control it at very low levels so that it does not cause any harm. And there are various ways to do this. One of these would be to provide antiretroviral therapy as early as possible following HIV infection. And then, because the virus does not completely disappear, an intervention can be done with what we call latency reversal agents. These latency reversal agents force the virus to come out of the tissues and the cells where it is hiding, so that it can then be inhibited by antiretroviral therapy and other strategies. This can then be combined with immune boosting, and this can be done through strategies such as vaccines, immunotherapies, antibodies. This enhances the immune system and enables the immune system to control the virus. But we should also not forget that we are all working towards a one-shot cure strategy. And gene therapy offers real hope for achieving a one-shot cure, although it is probably a decade or more away. I would also like to point out that in addition to developing the final products for HIV cure, HIV cure research is challenging and multifaceted. And for example, we need also to work on developing biomarkers to anticipate viral rebound, because our goal in HIV cure is to have individuals come off antiretroviral therapy. And we know from studies that have been done that in some cases, individuals rebound when antiretroviral therapy is interrupted. And so one of the things that we need to be working on is to develop biomarkers that would help us to anticipate or to predict the individuals that will experience viral rebound and when they will experience viral rebound, because this would then move the field of HIV cure research forward. And recent studies suggest that this is in fact possible. It is possible for us to develop biomarkers that might be able to predict the time to rebound or detect individuals before a viral rebound occurs, so that there is no harm to the patient once the virus rebounds, and so that the person can be cared for. So all of this is part of HIV cure research, and this kind of research needs to be prioritized, particularly in resource-limited settings. I'd like also to highlight the recent development of a target product profile, which I believe is a significant milestone that will guide the development of cure strategies relevant to low and middle income countries. A target product profile, or TPP, helps to align all stakeholders by broadly defining the regimen or product that the community wants to develop, or that the community should develop for the field. It forms the North Star that defines the minimally acceptable and the optimistic interventions that should be put in place in order for us to move towards an HIV cure. And the TPP will evolve based on breakthrough scientific developments and changing patient needs. So a target product profile was recently published by key stakeholders in this journal, Lancet HIV. And in a nutshell, this TPP calls for a truly transformative intervention that will address the needs of those who, for whatever reason, are unable to access, adhere, or respond to antiretroviral therapy. Some of the conditions for this target product profile is that it should be effective. For example, at a minimum, one should be able to have a remission when given this product for at least 2 years, have a viral load that does not rise above 200 copies. It should be effective in more than 20% of individuals, and the average relapse per year should be less than 10% for this target, product to be useful in HIV cure. It should work in all populations, including in individuals who are viremic. It should be scalable. It should be able to prevent reinfection, although that is optimistic. And a single dose administration would, of course, be most favorable, although we may not be able to achieve that immediately or right away. So how are we going to move towards HIV cure strategies? We need human studies to inform HIV cure studies, particularly remission, HIV cure remission, in resource-limited settings. So what are some of the approaches that we need to explore in order for us to move towards HIV remission or HIV cure? The first option that many researchers are exploring is strategies for reducing the reservoir, the amount of virus that is hiding within cells and within tissues, and also how to preserve immune function in people living with HIV/AIDS. One of the ways to achieve this is through antiretroviral therapy, early antiretroviral therapy, as quickly as possible after somebody gets HIV infected, for example, during acute HIV infection. Another approach would then be to intervene with a latency reversal agent, a drug that forces HIV to come out of hiding so that then antiretroviral therapies can inhibit that virus. Other strategies include immune modulating agents such as broadly neutralizing antibodies that can go inside the cells where the virus is hiding and also within the tissues and force the virus to begin replicating and also activate new immune responses. Other ways to induce these anti-HIV immune responses would be through vaccines, and there are many vaccines now that are entering clinical trials, as well as immune modifying agents, including gene therapy and as well as anti-inflammatory treatments. Now, it is hoped that a combination of some of these approaches will eventually lead to HIV cure. But as I mentioned, we need to make sure that this research is being done in the areas of greatest need, and this is in the low and middle income countries, particularly sub-Saharan Africa, where the burden of HIV infection is huge. So the current landscape for HIV treatment is that we have a daily pill antiretroviral therapy, and that's what most people living with HIV are using. The hope is that in the near future, we will have long-acting antiretroviral therapies that can be used maybe for 3 to 6 months and durably suppress HIV replication. Broadly neutralizing antibodies have also made significant progress and may soon enter clinical use. These can be administered again for 3 to 6 months so that they can suppress the virus and lighten the burden of daily antiretroviral therapy on individuals. But eventually, we will need cure modalities. And for us to develop these HIV cure modalities, we will need to go stage by stage. First, by developing what I would call first generation, and then second generation and third generation HIV cure strategies, most likely through combination approaches, before eventually we have a single shot cure that can be applied perhaps through gene therapy. But I'd like to emphasize that the single cure strategy is probably a decade away. But the time to start working on these strategies is now, so that we can learn as we go along and make sure that the products that are developed will be the products that people desire to use and that will be acceptable and that will be effective and safe. So in conclusion, we have made tremendous progress in HIV prevention and treatment, but the current approaches are suboptimal. More needs to be done to optimize the current effective strategies. There is room for innovation in HIV prevention and cure approaches, and this will be needed to end the HIV/AIDS epidemic. Combination approaches involving early treatment, latency reversal, and immune-based therapies are currently the most promising HIV cure strategies. And I also want to highlight once again that cure research must prioritize resource-limited settings with high burden of HIV infection. And this was discussed recently in these 2 papers that I have highlighted here, one in Nature last year, and another one, more recent paper in Lancet HIV. And finally, I'd like to thank my colleagues that I work with at the University of KwaZulu-Natal and the Africa Health Research Institute in Durban, South Africa, the study participants who participate in our studies, and I have also generously benefited from colleagues who have shared ideas, slides, and data with me. And I also like to thank the many groups that fund our research in South Africa. Thank you very much.